You've been calling it snoring. Your partner complains about the noise. You wake up tired. You fall asleep during the day. You've explained it as age, as poor sleep quality, as something everyone over 60 experiences. A 2015 study published in the journal Sleep Medicine has a different word for it. And that word predicts stroke risk more accurately than your cholesterol level. Researchers at the University of São Paulo performed polysomnography, full overnight sleep monitoring, on 66 patients within 24 hours of their first acute stroke. They measured every breathing pause, every oxygen drop, every sleep position change. 78.8% of those stroke patients had obstructive sleep apnea, not mild breathing irregularities. Clinical sleep apnea, with an average of 29.7 breathing pauses per hour. That's one oxygen-depriving event every 2 minutes, all night, every night, for months or years before the stroke occurred. And here's what makes this finding devastating. The American Academy of Sleep Medicine estimates that 80% of people with obstructive sleep apnea, nearly 30 million Americans, don't know they have it. They're calling it snoring, while their brain is being deprived of oxygen 30 times per hour. Medical research identified 4 specific mechanisms by which untreated sleep apnea produces stroke. 4 pathways that operate silently every single night, while you're unconscious and unable to detect them. Reason 3 is the one that produces permanent vascular damage, even on nights when you don't have a single apnea event. And reason 4 explains why the stroke happened at 3 a.m., when most people think they're safest. We'll go through all 4. But I'm not starting with the obvious one. I'm starting with the one that your body experiences between 10 and 60 times per night. But that leaves no memory trace the next morning. And reason 4 connects the sleeping position you've been using for decades to a measurable increase in stroke severity. Not just stroke risk, the severity of brain damage when the stroke occurs. Reason number 1, oxygen desaturation. Your brain was suffocating while you slept. Think about the last time you woke up gasping, or the times your partner told you that you stopped breathing during the night, or the mornings you woke up with a headache, the kind that feels like pressure behind your eyes. Do you wake up with morning headaches more than twice a week? That's your brain signaling oxygen deprivation that occurred during the night. During an apnea episode, your airway collapses completely. No air moves in or out for 10 seconds, sometimes 30 seconds, sometimes longer. Your diaphragm continues to contract, trying to pull air in, but the airway is blocked. Oxygen levels in your blood begin to drop. Normal blood oxygen saturation is 95–100%. During sleep apnea, saturation can drop to 80%, to 70%, in severe cases to 60%. Your brain, which requires 20% of your body's oxygen supply despite being only 2% of your body weight, is now operating in a state of acute hypoxia. Brain cells begin to suffer, not die immediately, but suffer metabolic stress that accumulates over time. The 2023 INTERSTROKE study, a massive international case control analysis of 4,296 participants, documented that breathing cessation during sleep increased stroke odds by 2.87 times. Not a small increase, not a marginal risk, a near tripling of stroke probability. And this was after adjusting for age, hypertension, diabetes, and smoking. The oxygen drops alone, independent of every other risk factor, were sufficient to produce this magnitude of increased stroke risk. Here's what makes this mechanism insidious. You don't remember the apnea episodes. Your conscious brain never experiences them. You fall asleep normally. You wake up the next morning with no recollection of the 40 times your breathing stopped during the night. But your vascular system remembers. Your endothelial cells remember. The cumulative damage is recorded in arterial wall thickening, in oxidative stress, in inflammatory markers that persist into the daytime. A sleep study, polysomnography, measures your apnea-hypopnea index, the number of breathing pauses per hour. AHI under 5 is normal. 5/15 is mild apnea. 15/30 is moderate. Above 30 is severe. If your AHI is elevated, CPAP therapy, continuous positive airway pressure, keeps your airway open throughout the night. It's not comfortable initially, but it prevents the oxygen drops. And studies show CPAP reduces stroke risk in apnea patients by 40–50% when used consistently. That's reason 1, oxygen starvation that happens while you're unconscious. Reason 2 is what happens in the seconds after each apnea episode ends, when your body tries to recover. Reason number 2, blood pressure spikes. The surge you never felt. Your daytime blood pressure is controlled. You take medication. Your doctor says your hypertension is managed. But you still had a stroke. Or you're experiencing symptoms that suggest vascular disease despite normal daytime readings. Has your doctor ever measured your blood pressure during sleep? If not, they've never seen what your cardiovascular system experiences during the 7 to 8 hours when apnea is active. When an apnea episode ends, when your brain finally rouses you enough to gasp and reopen your airway, your sympathetic nervous system activates violently. This is a survival response. Your body detects the oxygen crisis and floods your bloodstream with adrenaline, noradrenaline, and cortisol. Your heart rate spikes, your blood vessels constrict, your blood pressure surges, not gradually, violently, from a sleeping baseline of 110/70 to 180/110 in seconds. This is not a normal nocturnal blood pressure variation. This is a hypertensive crisis, repeated 30, 40, 50 times per night. A review published by the American Heart Association and the Lancet Neurology identified these nocturnal blood pressure spikes as one of the primary mechanisms linking sleep apnea to stroke. Each spike damages the endothelial lining of your arteries. Each spike increases arterial stiffness. Each spike creates micro tears in vessel walls, where atherosclerotic plaques can form. And this happens not once, not occasionally, every single night, for years. The blood vessels in your brain, the ones that will eventually rupture or clot during a stroke, are experiencing this mechanical stress repeatedly. Your daytime blood pressure medication cannot protect against these nocturnal surges because they occur too rapidly and too frequently. The medication maintains your baseline, but it cannot prevent the spikes triggered by apnea-induced sympathetic activation. Ambulatory blood pressure monitoring, a device worn for 24 hours that measures pressure every 20–30 minutes, including during sleep, can reveal nocturnal hypertension that daytime readings miss. If nocturnal spikes are present, treating the underlying sleep apnea with CPAP is more effective than adding another blood pressure medication. Because CPAP prevents the apnea episodes that trigger the sympathetic surges in the first place. 2 reasons, both invisible during the day, both measurable only during sleep. Reason 3 is metabolic, and it's the one that produces damage even on nights when your apnea seems mild. Reason 3, chronic inflammation, the fire that never stops. You have elevated C-reactive protein. Your doctor mentions inflammation but attributes it to age, to arthritis, to general metabolic syndrome. You're taking statins for cholesterol, blood pressure medication, maybe metformin for insulin resistance. but the inflammation markers remain elevated. Is your HSCRP above 3.0 mg/L, despite taking anti-inflammatory medications? Sleep apnea produces inflammatory cytokines that no medication can fully suppress because the source reactivates every night. Intermittent hypoxia, the repeated oxygen drops and recoveries that define sleep apnea, triggers a cascade of inflammatory responses. Each oxygen desaturation event activates nuclear factor kappa B, a master inflammatory regulator. This triggers the release of pro-inflammatory cytokines, interleukin-6, tumor necrosis factor alpha, C-reactive protein. These cytokines circulate through your bloodstream. They damage endothelial cells. They promote oxidative stress. They accelerate atherosclerotic plaque formation. They make existing plaques more vulnerable to rupture, and critically, they don't disappear when the apnea episode ends. They persist into the daytime, accumulating with each successive night of untreated apnea. Studies measuring inflammatory markers in sleep apnea patients show chronically elevated levels, not just during sleep, but throughout the 24-hour cycle. Your immune system is in a perpetual state of low-grade activation. Your vascular system is experiencing continuous inflammatory assault. And this assault is cumulative. 5 years of untreated sleep apnea produces more vascular inflammation than 5 years of smoking. 10 years approaches the inflammatory burden of uncontrolled diabetes. The inflammation doesn't require severe apnea to accumulate. Even mild sleep apnea, 5-15 events per hour, produces measurable increases in inflammatory markers when sustained over years. The damage is dose-dependent and time-dependent. More apnea events per night equals more inflammation. More years of untreated apnea equals more cumulative vascular damage. Treating sleep apnea with CPAP reduces inflammatory markers within weeks. Studies show HSCRP dropping by 30 to 40% after 3 months of consistent CPAP use. IL-6 and TNF-alpha similarly decline. The inflammation reverses when the oxygen drops stop. But the reversal requires consistent treatment. CPAP use at least 4 hours per night, ideally 7 to 8 hours. Intermittent use produces intermittent benefits. The inflammation only fully resolves when the nightly hypoxic insult is eliminated. 3 reasons, all mechanistic, all operating silently. Reason 4 is positional, and it's the one variable you can change tonight without any medical intervention. Reason number 4, supine position. Why sleeping on your back multiplies everything. You sleep on your back, always have. It feels natural, comfortable. You've never questioned whether your sleeping position affects your health. Why would it? Does your partner say your snoring is louder when you're on your back? That's not coincidence. That's gravity making your airway more likely to collapse. When you sleep on your back, supine position, gravity pulls your tongue and soft palate backward, toward the back of your throat. This narrows your airway, makes it more collapsible, makes apnea events more frequent, longer in duration, and more severe in terms of oxygen desaturation. The 2015 sleep medicine study I mentioned at the beginning documented sleeping positions in 66 acute stroke patients. The median percentage of sleep time spent in supine position was 100%. 2/3 of patients spent their entire night on their backs. 78.8% spent no time sleeping on their left side. 74.2% spent no time on their right side. And critically, there was a significant correlation between percentage of time in supine position and stroke severity measured by the NHSS scale. More time sleeping on the back correlated with worse neurological deficits after the stroke. Not just higher stroke risk. worse outcomes, larger areas of brain damage, more severe disability. Because supine position produced more severe apnea events, longer pauses, deeper oxygen desaturations, which caused more vascular stress. Side sleeping, left or right, doesn't matter, reduces apnea severity in most people. The airway remains more open when you're on your side. Gravity no longer works against you. Studies show that positional therapy, training people to sleep on their sides instead of their backs, can reduce apnea events by 42 to 50% in patients with positional obstructive sleep apnea. Positional therapy can be as simple as wearing a device that vibrates when you roll onto your back, or as low-tech as sewing a tennis ball into the back of your pajamas. The goal is to make supine sleeping uncomfortable enough that you naturally shift to your side. Combined with CPAP, if apnea is moderate to severe, positional therapy addresses one of the modifiable risk factors you can change immediately, without medication, without surgery, without complex medical intervention. 4 mechanisms, all of them nocturnal, all of them operating while you were unconscious, none of them leaving obvious daytime symptoms. And here is the finding that changes how you understand what your snoring has been signaling. Your snoring wasn't annoying your partner, it was warning you about brain damage. Between 14% and 44% of all strokes occur during sleep. Not during the day when you're active and stressed. During sleep, when you should be recovering, when your body should be repairing itself. Instead, for people with untreated sleep apnea, sleep becomes the most dangerous time of the 24-hour cycle. And the mechanism explains why. Strokes that occur during sleep are strongly associated with sleep-disordered breathing. Studies estimate that sleep apnea is the suspected trigger for 50 to 70% of strokes that happen at night. Not hypertension alone, not diabetes alone. The nocturnal breathing pauses, with their oxygen drops, blood pressure spikes, inflammatory cascades, and positional vulnerability, create the perfect conditions for a vascular event. The snoring you've been tolerating for 10, 15, 20 years wasn't a minor annoyance. It was an audible marker of airway obstruction. Every snore represented partial collapse of your upper airway. And when that partial collapse became complete collapse, an apnea episode, your brain experienced oxygen deprivation. Your blood pressure surged, your inflammatory system activated, night after night, year after year, until the cumulative vascular damage reached a threshold. That threshold, when arterial plaques rupture, when blood clots form, when oxygen-starved brain tissue begins to die, that threshold is a stroke. And for 78.8% of people who have strokes, sleep apnea was the undiagnosed, untreated condition pushing them toward that threshold every single night. Here is what the research gives you. Not a diagnosis you can't change, a mechanism you can interrupt. The 4 pathways documented the specific nocturnal processes producing vascular damage, which means interventions that address those processes can prevent progression, and in many cases, reverse existing damage. The oxygen desaturations that damaged your endothelium stop when CPAP keeps your airway open. The blood pressure spikes that stressed your arterial walls disappear when apnea events are eliminated. The chronic inflammation that accelerated atherosclerosis resolves within months of consistent treatment. The positional vulnerability that made everything worse changes tonight if you train yourself to sleep on your side. This is not fast. The vascular damage accumulated over years of untreated apnea. Full vascular recovery takes time, 6 months to 2 years, depending on severity. But the mechanisms that produced the damage are not irreversible. They are modifiable, responsive to intervention. and they stop operating the moment you address the underlying sleep-disordered breathing. Studies following sleep apnea patients treated with CPAP show stroke risk reduction of 40 to 60% compared to untreated patients. Not a small benefit, not a marginal improvement, a halving of stroke probability. Because when you eliminate the nocturnal oxygen drops, the blood pressure surges, the inflammatory cascades, you remove the primary driver of nocturnal vascular stress. The snoring that embarrassed you may have just given you the information you need to prevent a stroke before it happens. While intervention can still change the trajectory, snoring is what you call it when you don't understand the oxygen mechanism. The sleep medicine literature calls it obstructive sleep apnea. The stroke research calls it an independent risk factor for cerebrovascular events. And that apnea, the one that has been operating every night while you slept, is detectable, treatable, and reversible if addressed before the vascular damage becomes irreversible. That is not a comfortable diagnosis. It is a life-saving one. Leave a comment. Which of the 4 mechanisms did you recognize in yourself? And have you ever had a sleep study? Because the next video documents the exact sleep study protocol, what an overnight polysomnography measures, what the results mean, and the treatment thresholds that determine whether you need CPAP, positional therapy, oral appliances, or surgical intervention. And the one symptom that signals your sleep apnea has already caused measurable brain damage, detectable on a standard MRI. Always consult your doctor. This video is for educational purposes only.